Hey, I'm freaking because I see Ann Deacon. Hi, Ann. Welcome everybody, and go ahead, Dan.
Yeah, thanks, Barry. Appreciate that. Barry's shown really great leadership in this process, and I want to acknowledge that. Ann Deacon, I want to acknowledge her for coming out of retirement for 1 hour to help us here. Ann is, I probably owe her a cup of coffee or something like that. And she's timing us. Ann has been instrumental. She's been a mentor of mine for years, and just has an extensive background. Ann Deacon was a warden at Monroe. She's worked with the health department for years and really helped us, I think, really connected the health department to the city of Bellingham. Today, Ann Beck asked me to write a brief letter of gratitude to the Whatcom County Health Department, and I spoke about the good relationship that the county and the city has now. Wasn't always like that, but does have now and has had for several years. And Ann Deacon was at the center of a lot of that. So Ann, just want to acknowledge and thank you for volunteering for an hour. I know you hate to be in the spotlight, so I'll get you out of there. SAC members, thank you for joining us today. This is, we're going over Behavioral Health Committee, Subcommittee of the Incarceration Prevention and Reduction Task Force and the work that committee has done. We have worked really hard to try to diversify the membership of that community. And by that, I mean, we have people like Chris Cochran, who's the mental health director for the Bellingham School District. We have Brian Thane, who is the head of the Bellingham Housing Authority to provide housing perspective. My co-chair, Mike Parker, couldn't make it today, but he has clinical background as well as working at the Opportunity Council and headed up the Homeless Service Center for some time. So quite a bit of good background. And we focus in on behavioral health solutions and policies that help prevent and reduce incarceration, but also balancing that the community needs to be safe. And so we're constantly working towards that. Under Sheriff Chadwick is another great member of the team here, and he provides a law enforcement perspective. And I hope he might have some comments later about a co-responder model, maybe when we're having our discussion at the end. So welcome everyone, and I'm going to go ahead and turn this meeting over to Jackie Mitchell.
Hi everybody, my name is Jackie Mitchell and I am a behavioral health program specialist. And can you hear me okay? Great. I wanted to just acknowledge that it's so exciting to see so many faces on the screen. It just tells me how important and how critical this issue is, the nexus between and the interface between criminal justice and behavioral health is just so vital to the important work that you're doing. And most importantly, I think I'd like to give a shout out to those people that are volunteering for this process, because I know what a heavy lift it is. And I'm just really appreciative of the hard work that you're doing. So thank you so much. So I think I mentioned already that I'm a behavioral health program specialist, and my job, generally speaking, is contract management and administration of funding, as well as program development. Some of my work involves the interface that you're looking at between criminal justice and behavioral health. So I think that's partly why I'm here to talk to you today. What I thought I would do is provide an overview of the funding and administrative infrastructure. And then I thought I would just barely touch on some of the gaps analysis work that we're doing. And that would lead me to talk about the jail behavioral health program and the reentry services, and sort of outline some of those gaps and needs that we have. So, and I will pause between the sections. I hope that I remember to pause between the sections and ask for clarifying questions. So
can I jump in real quick, Jackie? I've got a couple of folks with their mics on. I think Cliff and Kristen, your mics are on. There was a little bit of feedback coming through. I just want to make sure we're all good. And I think Kristen, Hannah, if you can go ahead and just mute yourself, that'd be great. Thank you.
Okay, thanks. And then Jackie, you can go ahead and show the attachment, if you will, the first attachment. So this flow chart was designed to give you there are three goals involved in this flow chart. And one of them is to show who the major entities are that provide behavioral health funding and administration. And the second goal is to show sort of the complexity of the system, because it is a hugely complex system, and then to show the interrelatedness between the various entities. So that's what I'm hoping that you'll get out of this today. So beginning with the State Healthcare Authority, which we refer to as the HCA, they receive both state and federal funding, SAMHSA, Medicaid. The state funding would be things like general fund and some special proviso funding for behavioral health services. And they are largely, probably almost entirely, the main body that distributes funding at the state level down to essentially the regional level. Although they do contribute money to the MCOs directly. And in fact, the vast majority of the funding probably goes in that direction. And the counties also receive some of that funding directly. For example, our triage facility, the Crisis Stabilization Center, and the most recent legislative proviso is remodeling the old facility and fixing it up for the next set of services. So all of these entities get state and federal funding, and I want to focus at least briefly now on the Administrative Services Organization, which kind of becomes central to this whole process because way back a few years ago, I don't know, maybe 5, 6, 7 years ago, when the state first announced it was going to move towards integrated healthcare, the 10 regions in the state and the counties educated the legislators to utilize the existing systems that were in place through the regions. And so that system had been in place for, I'd say, 25, maybe 30 years. So it's been a really long-standing entity, and it's super well integrated with the counties. You see in this model, it's the 5 counties that belong to North Sound, Island, San Juan, Skagit, Snohomish, and Whatcom. And I think it's really important for you to know that the counties are integrated at every level of this organization. It's been through several iterations in that 20 to 25 years, and this is kind of a representation of the most recent iteration. Things are changing so quickly, I really can't even say how long that this particular flow chart will hold. We have 2 electeds on the board of directors, and our health department staff most all of the other committees, except for the advisory board, on which we have 6 positions that we appoint citizen representatives to. So the other 2 entities, managed care and the counties, I want to move over now to the left to the managed care organizations, because they're a very recent addition to this entire system, and they participate just on committees that I think have to do mostly with system coordination. The North Sound ASO, which is how we refer to it, the ASO or North Sound ASO, provides administration of behavioral health services and non-Medicaid treatment, as well as a lot of other projects and programs. And in fact, the HCA this year rolled out a ton of new funding, and we're going to see a lot more activity in that area, which the counties have usually picked up the gaps in the system. And so I see a lot of crossover really beginning to happen, more and more crossover, and it could be hard in a year or two to distinguish which entity is doing what, but this is kind of a representation basically of our existence right now in the behavioral health infrastructure. So I just wanted to pause briefly and see if there were any questions at this point. See, Michael?
Yeah, Jackie, thank you. I'm new to this, so I may ask some basic questions.
Sure.
The State Healthcare Authority, that is a single statewide organization, whereas the ASO, there's like what, 5, 6, 10 ASOs across the state?
Correct. Those are regional ASOs. And yes, it is one single healthcare authority entity.
and the MCOs. There's dozens and dozens of those that may overlap MCOs, or
So that's a
may
really
overlap ACOs.
That's a really good question. For this county, there are 5 managed care organizations. There may be others in other communities. I can't really tell you how many there are. Those are insurance companies, by the way. I failed to mention that, but managed care organizations are actually insurance companies. So I can't tell you how many there are throughout the state, but there are 5 in this region. Does that help?
Yeah, it does a lot. And finally, for the ASO, what is the approximate annual budget? How much passes through it? Really, I want to know more about what passes through it rather than what it takes to operate it. But it'd be nice to kind of know, generally speaking, what kind of funding level we're talking about for the North Sound ASO.
You know, Michael, I'm going to have to get back to you with that answer because it changed pretty recently. They have taken on a whole ton more money, and I'm not really sure what the figures are right now. So if I could get back to you with that, that would be great. Unless, Perry, do you know the answer to that off the top of your head?
I'm sorry, I don't. You know, it's obviously several million, but I don't know the exact number.
Okay, it would be nice if you could get back to me as an SAC member, because again, ultimately we're looking towards a funding mechanism, and it's just nice to know how big the universe is for this specific component of the behavioral health system.
Yeah, it's huge, and I will get back to you, Michael. That's a really important question, and definitely. Like I said, they've taken on so many. Just recently, they were telling us there were millions of dollars more coming. So I'm not sure we have the most up-to-date information on the figure. And Harriet, hi.
Hi, Jackie, nice to see you.
Yeah.
So this is really helpful. I don't know quite how to phrase it. Where does the ASO sit? Is it within the county? Is it a totally separate entity?
So it is essentially what is referred to as a quasi-governmental nonprofit organization. But the seat of it is actually in Skagit County, so it's kind of in the middle of these 5 counties as best as it can be. Yeah, it's so am I answering your question?
I think so. So the ASO employs a whole bunch of staff that do all of the
Correct.
ASO functions.
Correct.
Right?
Yes, they employ their own staff, and some of that stuff does administrative work. Some of that stuff conducts more direct services, such as regional teams to provide certain crisis services. Soon they're going to roll out one for children and families. But essentially the organization also contracts with Whatcom County to provide some services as well. And they also contract directly with agencies. Does that help, Harriet?
Directly with agencies. Okay, great. Right. And one more thing. So according to your chart, the MCOs handle all of the Medicaid reimbursed services, and the county handles all of the grant money, state funding, local funding, the non-Medicaid funding sources. Is that fair or maybe not?
Not quite. It's close. It's really close. So the MCOs provide all of the Medicaid behavioral health treatment services. And so if somebody needs to go to an agency and receive medication or get counseling, then that's what they fund if they're on Medicaid. And then the ASO administers funding for the non-Medicaid services for those people that don't have insurance. They also provide most of the behavioral health crisis services, although the MCOs also now provide some of the funding for those services. This is why I say it's complex and super always changing. And if you ask me tomorrow, it might look like everybody's doing everything. But the counties themselves, like over here on the Whatcom County piece, you probably can't see my pointer. I just became aware that you probably can't see my pointer.
Oh, yeah, you can. Sure.
I think that's Jackie, the other Jackie's pointer, but
oh, okay.
Yeah, anyway, we have traditionally, the counties have traditionally tried to provide services in the gap between whatever else was being provided by the ASO years ago, and it's one of its former iterations, and now whatever's provided between managed care organizations and the ASO. So we try to provide services in those gaps, but again, there's a lot of crossover happening. Good question. Thank you.
Thank you.
Cliff.
Yeah, you mentioned that there was going to be amongst these organizations a lot of overlap and crossover. And I'm just wondering, doesn't seem like the most efficient way to run something. I just was wondering why you would do that. And then it also would seem like it would have the potential of things falling through the cracks. Yeah,
I agree. I think that it could be dicey coming up in the near future here. First of all, I'm not sure. So this is how funding comes down from HCA. So it's their decision where the money goes. But I think our protection against that is to continue to coordinate those services, the system between one another. And so that's why I wasn't always a fan of this particular infrastructure, but I've become a much bigger fan because it's the one place where I think we can really go and hammer out systems issues between the three entities and between the providers as well. So, because it's usually them who are experiencing, or the participants or the clients who are experiencing the difficulties and the changes. So, does that help, Cliff?
Yeah, thank you.
Okay, and Peter?
Oh, thanks, Jackie. Could you give just a couple examples for the contracted agencies on both sides of this chart, and maybe one or two of the MCOs?
I'm sorry, could you ask that question one more time, please?
Sure. I'm just looking for a couple of examples of the contracted agencies on both sides of this chart and of the insurance companies, the MCOs.
Okay, yeah. Let's start with the insurance companies or the MCOs first. AmeriGroup, United Health Group, Coordinated Care, Community Health Plan of Washington, and there's one other one. It's not coming to mind at the moment. And then contracted agencies, Compass Health, Catholic Community Services, Lifeline Connections, CMAR, Community Health Services. Does that help, Peter? That kind of, yeah, okay. So the agencies typically that they contract with are behavioral health agencies, so they're licensed and certified by the state. The ASO for some of these special projects may be contracting with entities that are not necessarily behavioral health agencies. Okay, and Dan?
Yeah, I just wanted to point out the city's role in this. Counties, there are 39 counties in Washington state, and counties typically have the lion's share of behavioral health roles in the community. The funding that Jackie's outlining here, that's very typical in terms of counties. Now the city's role is a little bit different. So we do some investments in housing. While that doesn't on the surface necessarily appear to be related to incarceration and incarceration prevention, housing is at pretty much every intersection when it comes to people's ability to succeed upon release. And so I just wanted to point out the city does make investments. And I know I see the mayor's on the call. I don't know if Mayor Fleetwood wants to chime in, but typically it's been under the Linville administration, it was about $5 million a year. I know ARPA's changed that a little bit or has potential to change it. But we do work with the county on that as well. And then last year, House Bill 1590 was passed both at the city and the county level. And that accounts for $3 million at the city level. And I can't remember the total. I think it was $2 million at the county level. 40% of those dollars can be spent on mental health services. So there is a direct tie in there. So just wanted to give you all that information.
Right. And also Whatcom County has a behavioral sales tax that I think is around $6 to $7 million, and some other millage funds that we contribute to the process of behavioral health. But yeah, Dan, I'm glad you mentioned that, because the city has been a terrific partner in ensuring that people get some of their basic needs met. And certainly people with behavioral health issues and challenges have a lot of needs. So thank you for the reminder. Okay, so if there aren't any more clarifying questions on that particular part, we'll move on to talk about what I wanted to talk about next was the jail behavioral health program, which I wouldn't do it justice if I didn't at least mention the gaps analysis and the sequential intercept model. So Perry Mowry, the human services manager, is facilitating a huge process to update a body of work that was completed by the task force in 2020. And in that model, it utilizes a best practice, essentially what is a criminal justice continuum, to talk about the points, they're called intercepts, but the points at which we might intervene or prevent or help people with behavioral health needs get out of jail and ensure their stabilization. So you're gonna get an entire presentation, I think, on that in an upcoming meeting. Is that correct, Dan?
That is absolutely necessary for us to do. I know Perry's been working on that, but yeah, okay. I think it's essential that the SAC members really understand and have that framework for the SIM, the intercept model, and see where the gap analysis, or see where the gaps are and see where we're doing all right.
Okay, thank you. So Jackie is showing the reentry services inventory, which I'm going to talk about in just a minute. But first, I wanted to talk about in that gaps analysis, one of the programs that's going to be important to your work, because as I understand it, you exist to help determine the right size of a jail that we need. So what size does that jail need to be? And I'm not an expert in any way, shape, or form in that, but I administer a contract for the jail behavioral health and reentry services. And first, I want to say that national research indicates that between 15 and 17% of people in a jail have a serious mental illness. We think that figure is much larger because, and it depends on a lot of circumstances, but currently, for example, the state has shut down some of their institutions. And so a lot of times those people end up in the community system. And most frequently, the state doesn't provide enough resource for us to effectively treat them in our communities. I'll tend to shut down a whole ward or unit and, for example, stand up a clinic in the middle of the state or something. This just never seems like it's enough resource. So I just wanted to mention that and to say that serious mental illness consists of things like schizophrenia, people with schizophrenia, schizoaffective disorder, and bipolar disorder. So people with serious delusions and thought disorders. But there's a much bigger group of people that includes those people with serious mental illnesses that have mental health disorders. And we don't actually know, and SUD, substance use disorder, and serious mental illness are included in those mental health disorders. We have a whole diagnostics and statistics manual that's used by every professional to provide diagnosis and to ensure treatment for people with any behavioral health disorder, all those that I just spoke of. But we don't know the actual number of people with those other disorders. So we are talking about things like anxiety disorder, depression, post-traumatic stress disorder, things like that. So there's this whole range of people, and we don't know the numbers for people with general mental health disorders in the jail. We had a report in 2016, which the data is really old because they performed an analysis of people who had a Medicaid service over a period of 5 years and came up with some data about how many people had a mental health disorder in our jail, Whatcom County Jail, as well as had a mental health need a co-occurring disorder need, which is both mental health and SUD, and an SUD need. I can send that information if you think it would be relevant, but I didn't think it was terribly relevant at this point because it's so old, 10 to 12 years old. I wanted to talk about the program we have in the jail, which has provided services to between 13 and 1,600 people over the last 3 years. And that program is called the Behavioral Health and Reentry Services Program. It's currently being provided by Lifeline Connections, and it includes 2 mental health professionals, a reentry staff, a juvenile behavioral health staff, and a supervisor. And by way of continuing to talk about what we do in the jail, that work consists largely of suicide risk assessment, crisis intervention and stabilization, and behavior management, and medication management, which we do with the help of psychiatrists or ARNP, psychiatric ARNPs that come into the jail. Our jail, as you probably already know, is one of the few jails in the nation that is certified by the National Commission on Correctional Health Care, which means that there is a higher standard of care. In particular, it refers to responsiveness. So while our jail team receives about 2,300 to 3,000 referrals from each year from inmates, correction staff, and medical staff, they are expected to respond to those referrals within 24 hours. And so I was thinking about this just earlier today at how interesting that is, because we have maybe some of the best access in the jail to behavioral health treatment, at least in terms of promptness and rapid response. But what we're lacking is the best quality of care that we could provide. And that is mostly related to the fact that the jail has almost no confidential treatment space. There's like 1 room with remote ability. So the team is still talking quite frequently through the food hatch or by phone to participants. And it's quite awkward because a lot of times there will be people milling about, listening in on the conversation. It's just not, it's uncomfortable for everybody, the professional as well as usually the client. What we think we could use is 4 offices or a bullpen, 4 offices so the mental health professionals can get together, act as a team, conduct staffing, and talk about behavior plans for people, or a bullpen with 3 or 4 confidential rooms where they might also have at least one of those rooms that has remote ability access. And then an additional office space or clinic space for the psychiatrists that come in to conduct the evaluations and medication monitoring that's needed. And then it would also be great to have a classroom in this situation. In the current jail, there's 1 classroom if you've ever taken a tour, and it's a very tiny. I've actually conducted audits in this room and I found it almost claustrophobic for 1 or 2 people. But we need a classroom that would accommodate several people at a time, 8 to 12 at least. And I would really love it if that room could be managed by the mental health staff. The current classroom is managed by the jail, which, and not putting down the jail at all, but it's already, the schedule is full and all of these services are critical. But if we had one that the mental health staff was managing, they could set themselves up to provide the behavioral health services needed, conduct the classes they need, change the schedule as needed, and also invite community services to come in and conduct other classes as well. It would be helpful if we had another MHP in the jail that could help provide coverage for the other positions. And it would also help if we had another case manager or a peer for reentry services. And then I'm just going to pause and ask for questions again. Clarifying questions. Oh, hi, Raylene.
Hi, Jackie. That classroom you were talking about, is that the one that's off of the courtroom?
Yes, that is the one.
So just to add a little bit to that, Jackie, that that room is also used by court staff for hearings, for misdemeanor cases, for district court cases, for attorneys to meet with clients, confidentiality. So it doubles as not only a classroom, and it is very small. I can exaggerate that a little bit, but it's really small for us to be able to set up the computers that we've been using for Zoom links because of COVID. And so it's being used a lot more than just a classroom. So I just wanted to make sure that was clarified.
Great information. Thank you, Raylene. I really appreciate that. I knew it was being well utilized. I knew I couldn't possibly do it justice to talk about all the many uses, but thank you. Appreciate it. And Dan?
Yeah, I see that Chief Jones is on the call here, but she's listed as an attendee. I'm wondering if we can promote her to a panelist. I just want to ask her a question about current mental health, what she believes are the current numbers for mental health illness or substance use disorder within the jail currently. Chief Jones was with our behavioral health team, I can't remember, within the last couple of months, and had some really good updated information. It looks like she got promoted, I think.
Thank you very much. And I can tell you that we did run the numbers for people who are classified as seriously mentally ill, and that would be 38% of the population of the jail. And these are people who are exhibiting symptoms and signs of severe schizophrenia and schizoaffective disorder, and usually out of control on the manic side of bipolar disorder, because that's what's brought them to the attention of law enforcement. The other thing that we are increasingly starting to see is neuroscience has come out and identified that the use of methamphetamine seems to be creating a very schizophrenia type illness. And we're seeing that in conjunction with a standard diagnosis of schizophrenia or schizoaffective disorder. As kind of a rule of thumb, we anticipate that approximately 90% of our offenders struggle with substance abuse disorder. So there's an overlap with that and mental illness. It is a very needy population, and it's challenging sometimes to try and meet those needs. But I have to give kudos to Jackie and the health department, because they were, the end of last year, we had one part-time MHP, and they were able to negotiate contracts, which got us back to having 3 full-time folks dedicated to the jail, plus the juvenile individual, and that's helped a tremendous amount.
Oh, thank you, Wendy. That's super helpful information. I probably should have mentioned, I was going to mention it a little bit later, but one of our biggest challenges throughout the behavioral health system right now is the workforce challenge. I'm sure you've heard all about it, so I won't belabor the point. I will discuss it maybe just a little bit more in the reentry part, but in the jail program itself, we have, 5 positions, 3 of them are filled and 2 are still waiting to be filled. So, and I think that's pretty consistent throughout the behavioral health system, that anywhere from a half to 3/4 of the programs are staffed. So in other words, they're staffed at about half or 3/4 of the rate that they need to be. Michael?
Thank you, Jackie. Actually, quick one for Wendy. I missed the number. You said 38% of the jail population has a serious mental illness, and blank percent of inmates have substance abuse issues. What was that percentage?
We figure it's probably 90%.
90%. Okay. Wow. So I'm struggling with the idea of in-jail behavioral health services versus community-based mental health services. And it would be nice if we didn't need or feel compelled to keep people in jail, because that's where they could get services. It'd be nice if we could release them based on some other enlightened set of principles, knowing that they would receive similar or better services in the community. So the question is, when people might be discharged from the jail or released pre-trial, they would be leaving behind those in-jail services. Will they find as good or better services in the community? Will there be continuity of care when they leave the jail to the community? I mean, is there this perverse disincentive, right, to keep people in the jail because at least there they can get services? Or how much when we release them, which would be a good thing in some regard, would we be putting them into a new situation where they wouldn't have access to equivalent or better services?
Getting the reentry specialist back, and I'll keep it short, Jackie, I promise.
That's okay.
Getting the reentry specialist back has helped a lot. We were very, very much struggling at the end of last year when that position had not been able to be filled. And so a primary job of that reentry specialist is to try and get somebody hooked into services in the community. I can't promise you that all that happens all of the time, partially because the criminal justice system occasionally will give us no notification at all that somebody is going to be leaving custody and there's not enough time. One of the things that we've done with a position here in the jail is a corrections deputy who's been around for a very long time, works very well with a wide variety of offenders, has been assigned to our classification division within the Bureau. And he's very good about identifying individuals who are going to be running into problems. He's been hooking them into the GRACE program and to the LEAD program. And that's only been taking place the last couple of months. Some things that I would ask people to keep in mind is that in our community, as with every community in the state of Washington, the jail is the only no refusal place that people can get services. That every hospital, stabilization center, evaluation and treatment center can and does on a regular basis refuse to take some of the folks that wind up in jail. They do that because somebody is at a point in their illness where they're acting in a way that's potentially dangerous to the staff and to the other individuals who are in that facility. I can't blame the other facilities for doing it. Law enforcement will, oftentimes what will happen is the behavioral continue to escalate until they meet our criteria for booking, and we'll bring them in and we try to get them engaged in the jail. One of the things, and this will be the last thing I'll say and then turn it back over to Jackie, I don't want to blow out her organizational lesson plan kind of thing, but one of the things that would be my hope as a result of the information that's going out to a variety of different sources is that people would see the jail as a point of engagement. Because one of the things that we always run into is that people will be in complete denial that they have any kind of an issue at all. One of the things our nursing staff does is when we have released somebody with the medication they will need to help keep them stabilized, is to go out to the front of the jail within the next few minutes of their release, because in about 70% of the case, the offender has taken those medication and thrown them away. Again, that whole issue of denial is very, very strong in this population. And we don't want somebody else digging through the trash and picking up a medication that could have an adverse reaction to them. So it is something that people need to be aware of. Simply providing people with an opportunity is no guarantee that they're going to take advantage of it. But we work very hard and have some of the best MHPs that I've ever come into contact with in my 40 years working with this population. So now I'll be quiet.
Michael, I just wanted to address what you were saying on two levels. One is that I have been in that jail many times and I have never ever seen the kind of attitude that would suggest that anybody there wants to keep anybody in jail. Even the corrections staff have been overwhelmingly supportive of moving people out, getting them into the right place, getting them where they need to go. It's they've been terrific to work with, actually. And the other thing is, you ask if there will be good services on the other side, and I think that's the last part of my presentation, and the point at which I'll ask Jackie to show the last document is that there are a huge number of reentry services that our reentry person connects with, including LEAD and GRACE, etc. that are kind of new within the last 3 to 4 years that we have never seen before. Now, if we could get those programs all staffed up, I think we would really be doing something incredible in this community. But in terms of the funding coming into the community, in terms of the desire to help people and get them into the right service at the right time, it's all there. The people in the behavioral health system are on it. They are really working hard to try to make that happen. And I only meant to suggest that that the access is really quick in the jail because of the certification, the National Commission on Correctional Healthcare certification. We still would love to improve that quality by having confidential space and being able to provide more than just crisis stabilization services. We'd love to be able to do some training on social skills. We'd love to be able to provide some more psychoeducational treatment on people's illnesses and just various things like that. And so hopefully that helps between the 2 or 3 of us that we're talking. And Harriet again?
I'm not sure if you mentioned it way early back. Does everybody that gets booked into the jail get some kind of a psych and substance use eval?
That's a really good question. I would say, I'm not sure how many people get it. We have a small program you'll see on the reentry inventory for substance use disorder assessment, and that actually includes treatment coordination. And they take every referral from defense attorneys, every referral from the jail behavioral health program, every referral from the nurses who are providing the medication for opioid use disorder in the jail. So the answer is not everybody gets one. I'm not sure everybody needs one. Everybody probably needs a screening, but not necessarily a substance use disorder assessment.
Okay. I have lots of comments, but this is clarification, so I'm just gonna be quiet for now.
Yep, we're just about to get to that part of discussion. Raylene.
Keep this quick for you, Jackie. I just wanted to respond real quickly to Michael. I can tell you that from the court's perspective, that the judges in this county are very quick at authorizing credit for time served for those that want to go into treatment. However, most people that go into treatment don't necessarily have to stay there. It's not a lockdown facility as the jail. So they might not send them to jail. They might give them the option to go to treatment first. They say, if you go to treatment, then you don't have to go to jail. You don't have to serve this time. We're going to give you credit for that. But sometimes people are in jail and then they opt to do the treatment. They go to the treatment facility. They're in there for 1 or 2 days, they walk away. And then we end up having a warrant for them and the cycle continues. So as legislature doesn't have a lockdown requirement for those that require treatment, you're gonna see a revolving door.
There is, Raylene, I could be a little bit behind on this, but the last I knew we did have a little involuntary treatment process for substance use disorder services, but we were limited to by capacity. Like I think there's only 2 agencies in the state that can take people who have serious substance use disorders in which they can't seem to get off of that recycle road. So I can check into that and get back to this group as well. Anne?
Yes, I'm aware of the time, and I see that we are short on it. I did want to just respond, Michael, quickly to you, and just to let you know that community-based treatment is only helpful when the person is able to use it. And the issue that we find with addiction being so prevalent is that once somebody is under the influence, they really aren't able to take the benefit of treatment. And sometimes jail, not that that would be an ideal situation from a moral standpoint, but sometimes it actually provides the opportunity for somebody to benefit from treatment when they couldn't perhaps do so out in outpatient. And I can talk a lot more about that and, you know, just the neuroscience behind some of this, but
Cool. Sorry, Anne, I will just quickly go through that last piece and then hand it over to you. So Jackie, if you could show that reentry inventory. I just had a couple things to say. I'm not actually going to go through each service because they're pretty well described. But all I wanted to point out was that here locally, that third bullet, ground level response and coordinated engagement, which Ann Deacon was very involved in the setup of, and the one below this, let's see, below that is mental health court. That's not the one I meant. The law enforcement assisted diversion. Those two programs provide a really high level of coordination, system coordination through policy committees and program committees and management committees. And so that really works in our favor in terms of ensuring a good, healthy reentry conduit. And then the other thing I wanted to say is that the program that I described earlier, the Behavioral Health and Reentry Services, the agency Lifeline Connections also provides that peer pathfinder program for reentry, and the PACT program, which stands for Program for Assertive Community Treatment. And most of their services are there. They said they were finding a niche within the reentry pool, and we're really starting to provide a lot of those reentry services and connect with our jail reentry person. And so I think maybe we should abandon the questions, because you can read this and it's pretty self-explanatory, and just move into maybe Anne's presentation. Dan, do you think that would be?
Yeah, we're getting kind of short on time and I want to make sure that we don't go over. So if Anne can have your remarks, that'd be great.
Sure. Let me say, first of all, that Whatcom County is fortunate to have some experts in the field here. Wendy's been doing this work forever, knows quite a bit about behavioral health. Perry Mowry used to run the state program for the prison system in our county, or in our entire state, for addiction services. So those two folks have got a lot of experience. And then obviously you can hear from Jackie that she's been doing this work for a very long time and has a lot of information about the research behind it. I think the one thing I want to focus on today is really how does this impact, the discussions of jail planning and what is needed in a jail, who should be served in that jail, et cetera. And I will say, first and foremost, I think sometimes we throw everything into the bucket of mental illness. But what we do know is that it is very hard when somebody is exhibiting symptoms to differentiate between, is this person under the influence of drugs or alcohol, or is this person under the influence of a psychotic episode or some kind of mental illness? And so that is really critical. And of course, our jail does first come in. My internet's problematic, so my apologies. So one of the questions is always, what isn't effective in addressing behavioral health issues in the criminal justice system? And I think first and foremost, let me just talk about the research. There was quite a bit done back in 2005 to look at what reduced recidivism, what was most effective in addressing criminal behavior, because obviously what we hope for in the system and in the jail is that it helps to reduce future criminal behavior. And what they noted is that, interestingly, treatment for mental illness did not have a statistically significant impact in a positive way. It's the moral thing to do, just like if somebody has diabetes and they're in the jail, you treat them. That's what you have to do. If somebody comes in and they're actively psychotic, it is morally our obligation to treat them. It is also our federal mandate to treat them. There is actually a federal court decision that directs the entire nation that you must provide services and treatment to medically necessary conditions. So then what I would say is, okay, so what does make a difference? And what they did find is that treatment of addiction was one of the most effective ways to reduce future criminal behavior. And as you heard from Wendy, when you've got almost everybody in that jail battling substance abuse, if not addiction, this becomes really serious. And moreover, recently, what we found, and this is probably in the last 5 to 10 years, that the use of methamphetamines, which is a stimulant, creates a behavior in people that is very aggressive. It can be violent, it can be predatory, and these are really serious. Before, when it was maybe opiates, not that that isn't still a problem, but opiates is a central nervous system depressant, and it, you know, people tend to be a little bit more on the back burner, as opposed to when they're under the influence of a stimulant. So one of the things that we have been really concerned within the criminal justice system, not to mention the whole behavioral health treatment system, is that while we know there are medications that will help treat people who have addictions to stimulants, we aren't very good. I mean, we are very good at treating people who might have an opiate addiction. We have some medications to help, but that is not the case. We do not yet have a successful medical intervention for methamphetamines. So in terms of then the jail, what we know is that treating addiction takes consistent work over a long period of time. And the jail doesn't really hold anybody for a very long period of time. When they do, lucky for us, we might have an opportunity to actually help them with their addiction. But if not, then some of the things we're also looking at is certain medications that could be administered before release that would actually reduce their cravings and may help get them connected to treatment and then actually stay in treatment in the community. But I think also what we want to make sure that we understand about criminal behavior is that mental illness very rarely causes criminal behavior. From time to time, somebody might be actively psychotic and have delusions that, you know, they need to hurt somebody, either for their own protection or for some other reason. But those are really rare. Mental illness really rarely drives criminal behavior. Addiction, as we just talked about and heard, can in fact do that. But there are other causes of criminogenic thinking and behavior. And I can get into all that at some point if anybody's ever interested, but that's a whole body of research in and of itself, and one that we factor into some of our programs now. So for instance, our mental health court, you know, has a program to address criminogenic thinking and behavior, and any other programs that we have in the community, like LEAD, like GRACE, we really need to build in a solid program that impacts that. And there are some evidence-based programs out there that we do know help to build empathy and address criminogenic thinking and behavior. You know, the other thing that we do know also from research is that education, in fact, can help reduce future criminal behavior. So when we're thinking about the jail, I think there's two things we need to look at. One is, how do we keep people safe when they are unable to keep themselves safe? And those would be people who are either actively under the influence or who are truly experiencing symptoms of untreated mental illness and they just can't keep themselves safe. The only way you can do that in a jail is to have a separate location with, you know, on-site monitoring to keep those people safe. So that, from a moral standpoint, is something we should keep in mind as we look to the design of a jail. And then the second thing is, where do we have space? And Jackie referenced this earlier, but where do we have space to actually offer services to connect people and do that initial engagement? And again, if somebody's been in jail long enough to either come down off whatever their whatever substance they're under, maybe you have a brain that you can work with briefly to get them engaged. But again, these are things that can be really challenging in a jail that can keep people maybe for 3 days only, maybe 11 days. So that's why space and how we create the design of that jail is going to be really important, is to make sure that you maximize the ability to connect and engage with people who have these really serious problems. Let me think if there's any other thing I want to say. I feel like I'm doing the speed talking here. I think the other thing to be aware of is that sometimes mental illness is an equal opportunist, and it impacts people who are criminal in their thinking and behavior, and it impacts people who are law-abiding citizens. So just because somebody has a mental illness and is in jail doesn't mean they shouldn't be there. And it doesn't mean that might not be the best place for them. And I think sometimes, you know, we get to feeling really good and need to make sure we care for people with mental illness, and forgetting the fact that their criminal thinking and behavior may not be related to their mental illness. And therefore, some people need to be in jail, and either for their safety or for the safety of others. The other thing that we do know also is that I used to manage the state prison for offenders with mental illness. So this was a 400-bed unit in the state of Washington that took the most seriously mentally ill people in the entire state. And I could tell you lots of stories about that one. But one of the stories I will tell you is that often somebody would have a psychotic episode in what we call general population, a prison somewhere in the state. They would call me and say, this guy needs treatment and we need to get him out of here because we can't manage him. We'd bring him into our facility. We would stabilize that person's mental illness, give them meds, make sure we had the right interventions. And what we found out is sometimes for those who were particularly predatory in nature of their mental or of their criminogenic thinking and behavior, they became much more capable of figuring out how to predate on others and how to be very dangerous to our people who were really vulnerable in their mental illness. And so again, that's a fine line, but you have to also have experts in the jail who are aware of that. So just because you treat mental illness, sometimes it can exacerbate somebody's criminal behavior, and sometimes it can improve it significantly. And that's why you need the professionals in the jail on staff who know which way to go and how to keep people safe. So that was my quick blurb, Dan.
Thank you. Appreciate it. We're almost out of time. I see that Doug Chadwick is still on the call here under Sheriff Chadwick. If you're still there, I'm just wondering, this is kind of germane to what we're talking about. If you could maybe briefly talk about the new program, the COVID responder program that you all are going to be doing.
Sure. Good afternoon. Again, been on this committee for quite some time, and again, in the infancy of some of these programs, really looking at how do we divert people from the criminal justice system before they even end up in jail. So obviously, as a result of that, we now have the GRACE program, we have the LEAD program, we have MCOT, the mobile crisis outreach team that we utilize, and now there's discussions about alternative response teams, basically a non-law enforcement team that would respond to persons in crisis. Whether that's mental health or crisis related to a substance use disorder. So one of my concerns, obviously, the jurisdiction of the Whatcom County Sheriff's Office is outside of the municipalities. So along with that, and I know Cliff knows this, some of the response time is significant just because of the distance we have to travel. Whatcom County is, including the water, 2,500 square miles. So that's a lot of area for our deputies to cover. And one of the concerns when we were talking about providing mental health providers out in the field to provide services and respond where people are to try and divert them from the jail. My concern obviously was the safety of those behavioral health specialists that are out there. And I use the example, if they respond to a call that they don't believe requires law enforcement to someone out in Glacier, and they get there and all of a sudden those situations tend to be fairly unpredictable. They're dynamic. They are rapidly evolving. So if they found themselves in a situation where all of a sudden they needed assistance because it became a personal safety issue or safety to others on scene, to include the person they're trying to assist, that response could be delayed. So again, that was my concern, especially for some of the more remote portions of Whatcom County. And I know after some of the legislation last year, when it changed what law enforcement was allowed to do, especially in those civil situations where we're trying to assess somebody and potentially take them into protective custody to protect themselves or others, we heard a lot of concern from the behavioral health community about responding without law enforcement and some of the issues that they had surrounding their own safety if things did change. So one of the things that we discussed and I proposed, and I know it's being done in other counties and other jurisdictions, is a co-response model where you essentially have behavioral health specialists responding in conjunction with law enforcement. And again, that's in my mind, especially in some of the more outlying parts of Whatcom County, provides the most efficient response of both behavioral health and law enforcement services at the same time, providing those services where people are. And then when you get on scene, if it's clearly a behavioral health situation and not necessarily law enforcement needs to intervene, they can step back. The behavioral health specialist can step forward and do their job. And that's what their specialty is. If things do change and it becomes more of a safety issue and they need to back out, and then it becomes law enforcement can step forward and address the immediate safety concerns, we can get it stabilized and then again, turn it back over to the behavioral health specialist and again, provide people the services that they need, whether that's on scene or maybe even transporting them somewhere else. And what we were looking at as far as co-responder was both having behavioral health specialists ride with our deputies. The sheriff's office currently has 2 behavioral health deputies. That's a program we instituted in late 2019. And they prioritize calls that are identified as person in some kind of crisis, again, whether that's mental health or substance use disorder. And a lot of times we find there's co-occurring disorders. People are struggling with both mental illness and they've got a substance use disorder. So again, either they respond with us and they can ride with the behavioral health deputies and respond together. There's also, I know one of the units down in Skagit County has their own vehicle and then they can respond in addition. So then you're not tying up 2 resources, because again, you may find that you don't need one of those resources there. It's not appropriate. But if you're together, that's one of the downsides potentially to a co-responder is now you're both there on scene and law enforcement can't necessarily leave or behavioral health if it's not the appropriate resource at the time. So in a nutshell, that's really what we're looking at is there's a variety of different models we have. Again, just like anything else, there's not a one size fits all solution. Every person's situation is unique and different, and we want to have a variety of programs so that we can respond appropriately.
Thanks, Doug. And thanks, folks, for staying. We're a little over time here, but I thought it was really important to include that pre-arrest diversion program over at the Sheriff's Office, in addition to that list that Jackie provided. So I want to just say thanks to Ann Deacon, thanks to Jackie for organizing this and playing such a big role, and thanks Perry for contributing, and everyone for your questions. We need like a day to do this, not an hour, but I think that this is a good start. It's the complexities on behavioral health are huge, as you are learning. So I do want to figure out a follow-up on this to see if we can further discuss, but I do want to respect people's time, and I know it's past end of business today. So thanks for coming, everyone, and we will see you soon.
It's great to see you.
Thanks, Dan.
Thank you, Ann. Great to see you.
Thank you, Ann. Good to see you.
Good to see you, Ann. Bye-bye.